on. We're all working in this new technology era of Teams meetings, so we appreciate everyone's patience. 2 more minutes and we'll get started. You'll see that we're going to hit record at 6 o'clock, and we will record this and we'll be able to view it later. And then we'll follow the agenda. Sharon, can you see the agenda right now? Okay, excellent. I just want to make sure
I
it's
see it. Yeah.
Okay, fantastic.
Oh, thanks.
All right, so if everybody can just hold on another 2 minutes and we'll get started. Okay, thanks everyone for joining. It is now 6 o'clock. So I am going to turn it over to Chair DeJong to start us out. Thank you.
Thank you, Megan. Hello, everybody. Welcome to the Santa Cruz County Syringe Services Program Advisory Commission. My name's Sharon, and I am the chairperson. Disclaimer, I'm not familiar, I haven't done this in a really, really, really long time. So love me through this. So are we going to take roll? I'll just start. Commissioner Chestnut? Okay, cool. And Commissioner Hart?
Here.
Great. Vice Chair Bruder?
Here.
Great. Commissioner Sturm? Commissioner Gardner? And Commissioner King?
And Commissioner Sturm is here. I had myself muted.
Okay, cool. Great. Thank you.
Me too. Patty King.
Great. Thank you. Okay, so it looks like we have enough for quorum, or we have quorum. All right. Megan, was there anything else I need to do as far as introductions go, or are we good?
Yep, you're good.
Okay, great. All right, so do we have a motion to approve the minutes from November 10th meeting?
I'll make that motion. This is Commissioner Chestnut.
Okay.
I second.
Okay, let's move in second. Damon, you have our Vice Chair Bruder, you have your hand up.
Thank you. Good evening, everyone. I just wanted to review, I think it's section 8, number 5 would be the last page if you printed it out in the meeting minutes. That's where I had asked about the frequency of HIV testing offered and followed through on. In the answer, it says, shared that our county received additional funding for Hep C treatment and testing services. There are good outcomes when SSP and Hep C testing treatment are paired. Can share information about our testing rates, but difficult to determine who follows through on testing referrals. I would like it to be noted that the rest of the answer was that the SSP is not offering HIV testing at this point and has not since the instatement of the lockdowns and the COVID protocols. That was part of the answer that Jen had given to me, or given to us at the last meeting, and it was not included in the minutes. So I would like that reflected.
Okay.
That can be done.
Okay, great. Thank you. All right, so now do we do a motion to approve and second again since there's been a change, or do we just go ahead and vote yay or nay?
I think yes. Angela's saying yes. You can vote.
Yes, I'll make the motion to modify the minutes as per the recommendation of Commissioner Bruder.
Great, thank you.
This is Jim Hart. I just want to make, I don't remember that being said. I just want to make sure that we agree that that is what was presented to us.
I do remember that being said.
Okay, thank you.
Okay, thank you, Commissioner Hart. Okay, and do we have a second?
I'll second.
Okay, great. All right, and all those in favor?
Aye.
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 All right.
Aye.
Okay,
Aye.
all right. That looks like the ayes have it and motion carries and minutes are approved. Okay, great. Thank you, everyone. Okay, so now it looks like we are moving on to our presentations. The first one is from Rashawn Williams on the SSP update.
Good evening, all. Rashawn Williams here.
Hi, Rashawn.
Hello. Just making sure I can be seen. We are continuing to work on a staffing and scheduling to maintain our open doors during the furlough days with the assistance of volunteers and extra help staff. Successful in doing that thus far this past month, and we have plans to remain open during the furlough week between Christmas and the New Year. We are also working to maintain our experienced staff, including extra help staff, to make sure that their hours are being used judiciously so that they can continue to work in the exchange as long as possible. And continuing to train new staff and volunteers to work forward in the coming months, of course, to have staff to remain open. As far as our referrals go, planning on meeting to work on improving on that process. We have done some changes to the database to prompt our staff to follow up on treatment referrals and to questions, maybe a little harsh word, but to enter into conversations with participants as drug treatment is noted in past encounters. And an example of that would be that, oh, we noticed that this person has a referral to treatment. So we'd follow up with them to see how did that contact go? Were you able to get through to the individual, to the counselor? If they say, oh, well, actually, I didn't make the call for whatever reason, then we make sure to give them another flyer and try to hold their hand through that process. Or if they say that they made a call and they're having trouble getting through, then we at that point can contact our MAT counselors to make sure that there isn't a ball dropped. More often than not, though, it is someone who doesn't follow through on referral. And as we've discussed in the past, it's an anonymous program. So that linkage is something that we're going to need to continue to work on in order to to follow through, to make sure that we're following through with the individual. And as far as our litter abatement, we're maintaining our communication to respond to reports of syringe litter, contacting the Downtown Streets team, and also other community partners, including the Harm Reduction Coalition of Santa Cruz County, which is performing syringe litter abatement as well. And as always, working to improve the relationships that we have with our participants so that we can make referrals and also pass on important information as it comes up, including recent potential botulism case. So we're passing out information on wound botulism, which is carried in black tar heroin. So again, it's about relationship building so that we can have those difficult conversations with our participants. And that's about it as far as updates that I have.
Great, thank you. Does anyone have any questions or comments at this time? Vice Chair Bruder?
No, these formalities. Mr. Williams,
Yes.
question for you. I appreciate you being here, taking the time to update us, let us know what's going on. I know that you're a busy person with all the different hats you have to wear, and again, we really appreciate it. One of my questions is there, and this is concerning information given out to the clients in regards to syringe disposal, syringe possession, syringe litter. I was wondering how often, or is it commonly known that possession of a syringe is not illegal anymore? From my experience in the past, when I was a client, it was pretty much illegal to have a syringe. This was before they were decriminalized, before you could purchase them from the pharmacies, that kind of thing. And it was a minimum misdemeanor, 1 misdemeanor per needle if I got busted with those needles. So it was sometimes tough to choose to hang on to them for the exchange. And I was wondering, since it's decriminalized, since possession of syringes is decriminalized, is that put forth to the clients so that they don't feel that they have to throw them in a bush so that they don't get any charges?
Yes, we do pass out information, letting them know about I wouldn't call it decriminalization, but the fact that they can possess syringes. But I pair that with, I always promote the use of sharps containers and really pair that with that information, letting individuals know that the syringes should be need to be kept in sharps containers. If someone has them in a paper bag, for instance, I always point out that I realize that sometimes there's a stigma if someone is seen with a sharps container. If someone is trying to be discreet within their social setting, sometimes that sharps container is not desired. But again, I always point out the importance of it and its intent, which is to keep people safe. But we do give that information posted as far as the fact that syringes dispensed from an SSP are there's no criminality to it. Now, if someone is on probation or has any other thing, there's some nuance to that, as I understand. But is also, a loaded syringe is different from a clean syringe or one that, just has residue in it. But I always point out that we have syringe sharps containers here. We will give them out. That's the whole intent, and that they should be used as sharps containers and properly disposed of in those sharps containers. Mm-hmm. Sorry if that was a little long-winded.
That's quite all right. Every word you say is more information for us, and we appreciate that. So thank you very much.
Mm-hmm.
Thank you so much. Anyone else?
Hi. Okay, so I'm going to flash my ignorance at you right from the get-go. I don't know if I understand what our clients what their consciousness is about a syringe once they've used it. I don't really know if there's a period of time where somebody consciously says to themselves, okay, I got to handle this properly. I'm going to carefully put the lid on, and then I'm going to put it in my sharps container. I don't think that happens. But what does happen?
Well, if that's directed to me, that question, I would say that our participants, they vary in personality, like all of us. So there are many of our participants who are very conscious of the proper disposal of syringes, and actually within their community do their best to promote the responsible disposal of syringes. Now, like in any community, you have individuals who, whether, I'm not going to try to analyze their reasons. Carelessness, is a part of it. That don't dispose of syringes and any litter, for that matter, properly. But as far as to speak to the community of our participants as a whole, ones that use the exchange, I would say are, generally speaking, very responsible for their syringe litter. They are. Now, as I said, that doesn't speak to everyone within the community. Perhaps individuals who are, don't come in to dispose of their syringes. I can't speak to that. But in general, I think that there's a great responsibility for disposal of syringes in the community as a whole, of our participants and agencies that work to support them.
Jen has her hand up.
Hi, Chair DeJong. The question that Chair King had about what are the participants like, I think I was actually going to cover a bit of that in my report out. So I just wanted to put that out there. It's I will be reviewing, basically sharing my screen and reviewing the syringe access and disposal evaluation that we did last year. That will provide just a snapshot, a point in time snapshot into who the participants are that participate in SSP. So I just wanted to let you all know that I'll be covering that. We'll have more time for discussion.
Great, thank you. Okay, so, why don't you go ahead and do that, Jen?
Great, thank you. I'll go ahead and attempt to share my screen. Okay, great. So what you should see on your screen is it's a PDF of our syringe access and disposal study. This was, we developed this in public health from July through November of 2019 per the board's directive to evaluate syringe litter in our community. So we did do a visual inspection, a point in time visual inspection of syringe litter in certain areas. But in addition to that, we also did a client survey. We surveyed 133 individuals and conducted some focus groups to get a better sense of who our participants are and who and what are the demographics and the motivators and behaviors that sandwich syringe disposal. We want to know not just if people are disposing of syringes, but why they do it or why they don't do it. So that was how we took this directive and kind of shaped it in a public health fashion. The report is very long. It's 74 pages, but it has a lot of great information. I hope if you haven't already looked at it, please do. And again, I want to point out this is a point in time. Again, it's a snapshot in time of what we saw in terms of syringe disposal in our community. What I'm going to focus on this report is more the demographics and the focus group findings and just highlighting what we saw. But I will say from a syringe litter behavior standpoint, we did see, per Rashawn's comments earlier, we did see that many participants, or when we did the visual inspection, when we found syringes, they were typically contained in large containers already or large bags. It was as if someone left it there. And I think this shows a lot of things. One thing that it shows is the cleanup efforts that our community has invested in have been very good. We'll say that, because we know that these are areas that have a lot of injection drug use, and to see that just a random point in time visual inspection, we did see as much syringes there. It's not to say that syringe litter doesn't exist and that, and we're not saying that it's not a community concern, but what we are saying is that the investments made for syringe litter at the time of the visual inspection seems to have made a difference in terms of ensuring a clean environment. So with that, I'll just get on with this portion of the presentation. Just to do an overview of what's in this report, we have some background about our program and harm reduction services in California for syringe services programs. And then we have the 3 sections that are included in this evaluation. Individual field surveys. So again, we surveyed 133 people where we had a surveyor actually ask the people questions about demographics and their habits around syringe litter and syringe use. We had focus groups, and then we did a visual litter inspection. What we did for the individual field surveys, we actually went out into the community and we sent surveyors out to actually interview people out in the community. So it's not actually representative of our syringe program, because we actually went out and surveyed people who may not actually be our participants. We do have a few of our participants included in the survey, but the majority of them are those who are unsheltered just because of the nature of how we were finding people. So that's something to consider as well, is that you'll see a high proportion of people who are unhoused, and that's an inherent bias in the survey based on how we were outreaching to people. Okay, so I'm going to go to this figures and tables section, and I will make this a little bit bigger. So you can see of the 133 people that we surveyed, we had primarily people within the 25 to 54 age range. 83 or 62% of the people we surveyed were non-Hispanic white, 25% were Hispanic or Latinx, 29% are female, 69% were male, 92% were English speaking, 8% were Spanish speaking, and routine source of healthcare, because we also wanted to assess how often people were accessing healthcare services. 59% noted that they have a primary care provider. 30% said that they use an emergency room or urgent care. And 6% mentioned that they do not seek care. And scroll to the next slide. So this gives you just a visual of the age range of who we surveyed. Again, you can see primarily between that 25 to 54 range, or really 30 to 54 range. And because, again, we actually went out into the community, into neighborhoods, and approached people on the street, it's heavily biased towards people who are currently unhoused. So their current sleeping environment is 59% mention that they sleep in a public place. 11% say they have a place where they rent, lease, or own. 10% said they have a room or a house. 8% said car. And I will mention too, for our SSP participants, many of them are housed, stably housed. So that is actually where we were able to get a better sense of the experience of people who are housed and currently injecting drugs. So, and then for the zip code area, primarily people identified living in Santa Cruz, Live Oak. 29% said Watsonville and Freedom area. And that's also biased partly with how we were actually doing the outreach as well. We were trying to do more outreach in the Watsonville area, but we also, since this was guided by syringe litter, and the majority of syringe litter was really the Santa Cruz area, or Santa Cruz City area, that's where we were focusing the survey results of the surveying. And this is a map just to see the specific areas we chose to do the surveys. And we chose these areas after a meeting with organizations that conduct syringe litter collection. We checked in with participants. We asked organizations that frequently interact with people who inject drugs or work with people who are unhoused. And so that's how we decided on these areas, and also just thinking about our own capacity, like how many staff we actually had to do this in a short time frame. So the rest of the questions are really interesting. They go into, again, syringe litter behaviors and healthcare and health outcomes. I do want to share just a few quotes from the focus groups. This is a presentation that was presented at the Board of Supervisors on December 10th when we were presenting the findings from this report. And there are just 3 slides here, just some high level, and when I say high level, just very like, not super detailed, but just the themes that we found from these focus groups that were conducted is that there were some definitely shared values among the people who participated in the focus groups and the community who participated in our listening sessions, our community listening sessions, and who we work with. So we saw a value of safe environment. And here's a focus group participant quote: "I've always been more on top of that sort of thing because I stuck myself with a needle even before I started shooting. And so it kind of irked me, and I go out of my way to dispose of them." We hear that a lot, especially our SSP participants. Think by the time you have a participant who is able to make their way to the Emmeline or the Watsonville Syringe Services Program. They've already either figured out transportation, they are able to make the hours, because at the time we had our hours weren't as accessible. And so we do see a pretty high sense of self-care and awareness of the importance of self-care for themselves and for their community. Another shared value is accountability. Focus group participant said, you start somewhere, just having clean needles. Okay, I'm taking care of myself a bit. Sometimes that snowballs into, I don't want to use as much as I have been, it can. That's what harm reduction is, start somewhere. We hear that a lot as well from our participants, and Rashank and Danny, who's going to provide a presentation as well, can definitely speak more to this. People, they want to do, there's a desire to be well. There's a desire to do what they can. And there's a value of wanting to be accountable to actions. So that's been consistent, not just in the focus groups, but in our one-on-one interactions with participants. And then last is compassion. It's not just about needles, make them feel like people. And that came out, that again is something that comes out a lot in one-on-one interactions with people, those who use drugs. I can't tell you how many people I've had to bring back with Narcan in the past couple of years, but grateful for the opportunity to do it. So there's definitely a desire to be part of a community and to have sense of participation in community through acts of compassion. And again, I keep saying this is just a snapshot, but I do want to mention, I keep saying it because this isn't something that we can make broad assumptions from. It just gives you, it just opens up a crack in the door to give you a sense of who people who inject drugs, especially those who are unstably housed, what their behaviors look like, and it gives you a sense of their perspective when it comes to drug use and syringe litter collection. So I'll stop there, and after this presentation, I'll provide this document to Megan to send out to the commission. So you have that, and we'll also, we do have it on our website as well already.
Thank you so much. Thank you. Any questions or comments from the commission? Vice Chair Bruder.
Thank you. Hi, Ms. Herrera. How are you? Mike, one quick question is, when was this study done? What was the date of this?
This was done, it was released in December. The activities for it happened between July and November. And the visual inspection, we did a 2-week visual inspection of syringe litter in hotspots, syringe litter hotspots, and that was in October of 2019.
Thank you. Oh, of 2019.
2019, yeah.
So this is a year ago. Mm-hmm. Okay. All right. Thank you.
All right. Anyone else? Okay. Our next presentation is from Danny Contreras. Hi, Danny. Good to see you. You're muted.
There I am. All right. Cool. I was talking to you guys couldn't hear me. Hi, Sharon. Hi, everybody. So I'm going to put let's see if I can share this screen right now. Or maybe not. Let me see. I want to let me go right here. Can you guys hear me?
Yeah, we can hear you,
Yes.
and we can see it.
Okay.
Just disappeared.
It did disappear. Can you see it now?
Yep.
Okay, let's see. Teams, where'd you go, Teams? All right. So, my name is Danny Contreras.
Can we see your email?
Email? Ah, wrong one. Why is it doing that? Sorry about that. Hold on. Having technical difficulties here. Why is it doing that? Now can you see it?
There you go. Yeah.
Why is it? Again. See my Raiders.
To err is human. To really foul things up requires a computer.
Yeah.
Danny, would you like me to share my screen and I could roll through the slides for you?
Yeah, that would be good. For some reason, my computer's between these two screens.
Yeah, no problem. Just give me a moment.
There you go. Okay. I guess you'll just have to click. Jen, sorry.
Yeah, no problem.
Okay, so I dropped in the chat box our most updated and current MAP brochure. Again, my name is Danny. I'm the health service manager for our medication assisted treatment program, and I'll kind of go over all that stuff while we go through this presentation. So you see the first thing right there. Obviously, we're in a pandemic right now. A lot of things have switched and changed at our primary care clinics, workflows, and staff being out because of this. But one of the most dangerous things I would think is stigma. You know, sometimes a lot of our patients are stigmatized, judged, and I mean, people come here and they don't even want to get their own recovery sometimes because of that. And there's a lot of counseling and things that have to go into that. So Jen, you want to click to the next one? That's our program. We have 3 county clinics, HPHP, the Emmeline Center, and the Watsonville Health Center. You want to click to the... So some of this stuff I need to get a little bit updated, but this is from 2016. It shows Santa Cruz for overdose rates in 2016. You want to click to the next one, Jen? And then you see where Santa Cruz was ranking in 2014, 15, and 16 compared to the rest of California and the United States. Next one, please, Jen. So what is medication-assisted treatment? It's basically the use of medications in combination with counseling and behavioral therapies for the treatment of substance use disorders. A combination of medications and behavioral therapies is effective in the treatment of substance use disorders and can help someone to sustain their recovery. There's some links on there from SAMHSA that explains a little bit more. Jen, you want to click to the next thing? So these at our clinics right now, these are the medications we use: buprenorphine, naltrexone. Methadone we do not use. Everybody goes, if they're going to get services for that, they go to Janus, the methadone clinic in Watsonville, and here at the Emmeline campus too, not the Emmeline clinic. Can you go back, Jen? And so buprenorphine is Suboxone. There's a bunch of different forms of that. And we can read that real quick. Partial agonist, opiate, high affinity for receptors, low acting 36-hour half-life, no cravings, no withdrawal, no euphoria, normalizes the brain. So basically someone who wants to get off any type of opiates, if this is a good treatment for them, they can take a form of buprenorphine, which is Suboxone. You see the strips right there. I can't really point to it, but you see it's underneath the Vivitrol. And then naltrexone. We give out pills form, but most of it's injectable. It can be for opiate or alcohol. The majority of our patients that are on Vivitrol are for alcohol use disorder. And like I said, methadone is at Janus. You want to click to the next one now, Jen? So right now, I think it's a little bit higher because we have some more X waivers. Basically, a doctor needs to take a special course to be able to get X waivered, to be able to prescribe the buprenorphine, the Suboxone. And so right now across our clinics, we have I would say about 24 waivered providers, and the capacity to see probably more than 640 plus patients. So every doctor can see a certain amount of patients. Their first year, 30 patients, then 100, then it's about 260, depending on where they sit on that certification for that. We follow the hub and spoke model. So basically in 2016, around 16 or 17, some money came out to Janus, and Janus was considered the hub. And they started building relationships with all the primary care clinics that would participate to give addiction treatment. in the form of MAT to the patient populations. And so from that, we were able to build our team. And so right now, which I'll explain a little later, but right now we have about 7 drug and alcohol counselors across the county clinics. We have 3 nurses that we got through that, and I have 2 medical assistants and an admin aide. So that has helped us. Before it was just me when I first started, and one other case manager after that. That has helped us to be able to serve more patients. It was basically me running around all the county clinics and the homeless encampments, trying to get people connected and help them out. So now we have a pretty robust team. We're part of the Safe RX. We've been in working collaborations with many different agencies to develop bridges from the emergency room, hospitals, the jails, etc. So basically right now somebody can go to Dominican, and if they're in withdrawal and the doctor sees fit there, they can start them on Suboxone. They would give me a call right now, and I would get them connected to the clinic. And obviously it's up to the patient to follow up. Same thing with the jails. We've all been working on that for a little while, and they contact us as well now too, when patients are getting out and they start them in Suboxone, or they're just referring them, or vice versa. And so there's a lot of different collaboration going on there. We have given out probably way more than that, because some of this is a little old. 1,600 nasal doses to agencies, patients, and individuals during outreach. And SSP gives out about, and Rashawn probably have you better numbers for you now. Some like I said, some of my stuff is a little bit old. About 2,000 doses of nasal naloxone a year. You want to click the next one, Jen? So how does this work from SSP? So if somebody shows up at SSP, they're interested. I have a rotation of my case managers, my drug and alcohol counselors, doing shifts in the needle exchange when they can. So I try to get them in there at least 2 shifts a month, and they're there to be able to answer questions, talk to patients, get them started, get them connected to the doctor, primary care, whatever that looks like, and being that connection. If there's nobody there, then what they would do is they would call the case manager, or we have a new line. It's 454-4808, I believe. It's on the back of that map brochure I threw in the chat box. And so that will ring on all our medical assistants line, and they will connect the patient either that day or set them up with an appointment to see somebody as soon as they're available. So basically they get connected to the medical assistant or the drug and alcohol counselor, the SUDCM, which is substance use disorder case manager, and they explain everything about the program, how it works, and they get the patient in the program if they want to do that. If nobody's available, the SSP team will usually give them a map brochure, circle the numbers that they need to call on the back, and follow up with us. And then, so basically, if they come in with us, they make that connection. Our drug and alcohol counselors will do the intake, get all their labs and blood work ready for the doctor visit, see everything, check everything that needs to be checked to make sure they're ready to start this program. And so you want to click to the next one, Jen? So I kind of went over this. They basically set up an intake appointment with one of the SUD counselors. The patient will get assessed during that intake appointment to see if it's appropriate for them. We'll go over all the program requirements at this meeting, and then we'll ask the patient to submit a drug screen and some labs, some blood tests. And then they'll start coming to group, or they'll start meeting with us one-on-one. And then we'll set up all the appointment for the doctor. That can happen really fast. Sometimes it takes time depending on availability, but it usually can happen really quick, the same day, matter of hours. All that can get knocked down pretty quick. And sometimes if there's maybe it's a Friday, we assess with them, we check in with the doctor. Maybe the doctor will give them a bridge until Monday when we have some more time. Like maybe it's Friday at 5 or 4:55 and we close at 5. We will figure some way out to get them going and get all that situated for the patient. Next slide, Jen, please. So what if they don't want to do MAT and they just want support around SUD? Some people do not want to do any of the medications, and that's fine. We'll meet with them still. We'll check in with them. We'll see what other services they want to do. We can do a brief ASAM, get them connected to Si Se Puede, Sobriety Works, outpatient programs, the camp, Victory Outreach, Salvation Army, whatever they want to do. We have those resources that we can try to connect them to that. And then there's certain, I don't know if that has changed lately, but there was been drug medical where they would pay usually for 2 stays a year. I think there's been some changes to that. And so sometimes we get people in and do a brief ASAM and call Si Se Puede and get all that set up, and they go into Si Se Puede, or they go into Santa Cruz Residential, or we get them an IOP at Encompass, or one of the other programs. So whatever they want to do, we're here to kind of help them triage that. And then there is patients that don't take medications that just come to our groups for SUD support or one-on-one case management. You want to click to the next one, Jen, please? So that's kind of the workflow. They start with the drug and alcohol counselor. We get the labs. Sometimes that could be the doctor or the nurse checking in with them. They go to group where they do a one-on-one. Then they have their initial appointment with their doctor, whoever the provider is, those X waivers that I said that can prescribe that medication. The Vivitrol, they don't need a special license or training to do that. They kind of already can do that on their own. And then basically the doctor checks in with them after their initial appointment, as well as the drug and alcohol counselor sees how things are going, how the medication is doing, are they connected, are they staying connected, and then we set up a treatment plan with them. And so the doctor just follows up with that, and they continue to follow up, and they continue treatment based on the treatment tier that they are. And we have treatment tiers, which I can go over pretty soon here. You want to click to the next one, Jen? So these are our treatment tiers. We have 5 tiers. The first tier, 1 and 2, is basically they both count towards the 12 weeks, those first 12 weeks. We basically have them coming in every week, at least once a week. Sometimes it's a little more depending on what's going on with them. Tier 1 is basically they just started. So they just did an intake. They might not even be on the medication. We're waiting for their labs to come back. And as soon as they're on the medication, we move them to tier 2. But they start coming in, and we have groups weekly. And so as long as there's negative for all their drug screens, you can see everything on the left side where it says what we do. But as long as they're negative for all their drug screens, they're engaging in treatment, we move them to tier 3, which then they only have to come in every other week. And then same thing for those 12 weeks, which really is only like 6 weeks. If they need more support, they can always come back in. They can always come to extra groups, whatever they want to do for that support. We don't really stop nobody from that. And we do have people that come more than what they're required to. So as long as it's negative for all drug screens and positive only for their medications and the things that they're prescribed, they move to tier 4. That means they have about 6 months of sobriety, and they can come in once a month to group or to one-on-one depending on their treatment plan. And the prescriptions follow that as far as the Suboxone. If it's an injectable like the Sublocade, which is the injectable, the Suboxone, the medication, obviously, once they inject it, it stays in their system for a month. The same thing with the Vivitrol. And then tier 5, once they have a year of sobriety, they move to tier 5, and it basically individualized. So I have people that are on tier 5 that have been with us since I started in 2016. They got, I don't even know how many years I've been here, 3 or 4 years or almost 5, who came straight from SSP, underneath a bridge, got connected when we didn't even have MAT services at Emmeline yet, or really at Watsonville. They were coming all the way from Watsonville trying to find a bus or a ride to go to HPHP to get connected, because that's where I started my first group. And I have patients from when I first started that are doing great, and they come in once a quarter. The limit is, the bare minimum is they have to come in once a quarter, right? And so there's some patients that are doing really great, job, school, all that stuff, and they do that. And there's patients that are still doing really great, and they come in once a month or every 2 months. So it really depends on what works for them and how they're doing in their treatment. If anybody has a slip or relapse, we move everybody back to tier 2 just to monitor them. If it's just a quick slip, we can kind of catch that. We don't try to do anything punitive. It's basically like, here, we're here to wrap you around with support. Whatever that is, here you are. And if things are good, we'll move them back to tier 5. If not, if it's more than a slip and they're continuing to use, we'll keep them at tier 2 and we'll wrap them around with all the support that they can get. And that support is, can you click the next one, Jen? It might be on the next slide. No, it's on the next one. But these are our groups that we have right now. And I'll explain a little bit more during COVID of how this is looking. We have a few shared medical appointments. So basically a patient can come in and we do group with the doctor inside the group. And the doctor is able to take care of all their medication assisted treatment stuff, as well as sometimes their primary care and things like that. And then they also get the group experience. It's usually about 90 minutes to about 2 to 3 hours, depending on what's going on with certain patients. We have individual slots after group for everybody to kind of fully check in, but it kind of allows us to see a lot of patients at one time. And if people are doing well, they can get their medication and go. People that are not doing well, we can focus more of our attention on those patients. You want to click to the next one, Jen? So here we go. Here's some of the services. We have IBH, Integrated Behavioral Health. Some of our patients have co-occurring disorders, mental health, and so we will connect them to our IBH team, the psychiatry or therapists, get that going. Some of our psychiatrists are X-waivered, so they can also prescribe the medication. So sometimes it might be that they have a PCP with us, and then the psychologist, because of the mental health stuff, will take over their medication-assisted treatment medication like Suboxone or Vivitrol. And so it's a good partnership, and all of us kind of work really great together in integration with our patients. You guys already know about Syringe Services Program, acupuncture. We offer acupuncture for our patients, contingency management. So this is really cool. I just rolled it out again because we had to rethink how we were going to do it because of COVID. But basically, they just published us, I want to say in April, in the SAMHSA book for evidence-based practice for stimulant use disorder. So we've been rolling out a meth protocol for patients. There are certain medications that have some evidence that have helped patients that have been using meth to decrease using or stop using. And part of that other piece is contingency management. Basically, we have this fishbowl it's filled with gift cards and positive affirmations. And we have patients come in that are on tier 2 and 3, come in twice a week. And so they will come in for their group or their one-on-one. And if they test negative for everything, they get a chance to draw from that fishbowl. And they got possibility of getting some gift cards or a positive affirmation. The gift cards are ranged from $5 all the way to $50. They're for specific places that cannot purchase any kind of alcohol or anything like that. But it's like $50 at Ross, $15 at Subway, $5 at Starbucks, movies, pizza, a bunch of different things. So they come in twice a week. They come in, like, for example, they would come in Monday. They drug test negative. They'd be able to do one draw. We're doing the draw for them because of COVID. We don't want nobody touching too much stuff going on. So let's say they get the gift card. They come in Thursday again. They pee again. It's just a quick check-in. And then if they're negative again for all substances, they get 2 more chances. So they got 2 more chances to draw either a gift card or a positive affirmation. And so it's pretty cool. It's been proven to work. And like I said, it got published in the SAMHSA evidence-based practice manual that they did for stimulant use disorder. And so we did yoga when I first started. I'm going to leave that on there because I'm hoping that one of these days we'll be able to do that again and build that into our groups. It was really, really cool to do. The patients loved it. They got a lot of good skills as far as meditation, breathing, and all that kind of stuff. And then we have our groups and our shared medical appointments, and then our one-on-ones with our case manager, drug and alcohol counselors. And then we have a group of peer mentors that we have trained. Some of them are doing shifts in the needle exchange. Like I said, in March when this COVID hit, it kind of stopped everything. We stopped our groups. We stopped everything. So we had to rethink how we were doing things. And we got that back up, and we're working on getting more of our peer mentors cleared. I'm right now working with on a thing with UCLA to have this more formalized curriculum for our peer mentors to be able to train them a little bit more, give them a lot more skills. And I'm planning to roll that out soon a little bit more and get them more involved. And so the peer mentors some of them are already doing outreach when we go out to homeless encampments with our Watsonville team or HPHP team. Some of them are doing shifts at the SSP. I'm hoping to build that more up. Like I said, that kind of changed with the COVID and everybody kind of pulled back and stopped coming in. And then they're able to help out, facilitate groups. And it's always good to have them or our tier 4 and 5 patients in our groups, peppered or scattered throughout the groups because they have long-term recovery already. And it's good for patients to see them doing well and all that stuff. And then our outreach efforts out in the streets. Jen, you want to hit the next one? So serving our patients, we try to be patient-centered in everything we do, apply harm reduction, motivational interviewing, non-judgmental, and continuously shifting the culture in our clinics and our community. I could say that I think we've done a lot of that since I've started, and we've done a lot of work around that, and we've seen a lot of improvement in our clinics and across the county at different agencies and even out in the community. So next slide. So COVID-19 and Matt. So we stopped everything in March. Then we opened groups again, and we stopped them. All our patients are like, man, I want to come back to group. I need my support, man. I'm not doing well by myself. I need something. And we try to do some online stuff. A lot of our patients had a lot of technical difficulties with technology, as you see, and I had right now when we started this. So they weren't really feeling that. They were like, no, I want to come in person, man. And then people were like, I want to come even just drug test so you can see that I'm negative for all my things. I'm proud of that. And so we're like, all right, we need to refigure things out. So we basically reopened, and we're still running them to this day for right now. The max we're doing is 9 patients per group. And as you can see in the first picture right there, we have tents outside in the balcony. Here at Emmeline at Watsonville, we have tents in an enclosed area, so they have some kind of privacy. We had to create new consent forms that they would be all right with being outside, socially distanced. Everybody gets screened at the front door before they come in the clinic. And we run group outside. We have the doctor. You want to click to the next screen? Depending on what's going on, there's one of our whiteboards. Next screen, please, Jen. Depending on the doctor, some of our doctors are remote and some are not. If they're remote, I have this little cart that I was able to get and set everything up so I can roll it outside, and we can still interact with the patients through telehealth. And so that's how we've been able to manage our patients through that and get them the support they need. They love coming into group. So that's basically what we've been doing. All our stuff has been turned to going outside. If we are inside, it's everybody practicing the safety protocols and being with a door open somewhere or a very big space and 6 feet apart. But most of it's outside. We're going on walks, sitting at the patio table, maybe out there in the back patio. I got all my staff laptops now so they can be remote and be able to keep interacting with patients. All my staff has work cell phones too. So sometimes we're out in a homeless encampment or something like that. We can turn on this Teams, which is HIPAA compliant, and we can check in with the doctor and get a FaceTime right there and kind of move out and get some privacy and get our patients taken care of. So we really have had to adapt to a lot of stuff with this COVID. Next slide. This was the last one I have. I need to run the most current report, but this is what happened. These are all the case management visits or SUD counselor visits since I started. So 2016 was basically all me by myself at all the county clinics. 2017, I got a little bit of help. I think I hired somebody. And then 2018 was when we started getting more of that staff that I told you about. We started getting from the hub and spoke. And then 2019, which that only went to October because I need to run the other current ones. And that you could see all the patients encounters that we've had. So it's been increasing. You want to click the thing, Jen? And I love this the trauma tree, and this is some of the stuff that I share when I go out and do presentations at the police academy on stigma and addiction and all this stuff, or even with our patients are out in the community. But we don't really know the roots to everybody's own issues. And if we all, I don't know how many people have their own lived experience on this call or webinar or whatever, but we all have our own experience. And I know for myself that, everybody doesn't know all that stuff at that roots. And sometimes it's a lot of stuff that's hard to face. And it's about understanding that and, no judgment on nobody and getting them the help they need, Sometimes it's a simple thing like, hey, man, you need some socks? Well, let's talk, let's figure something out, And so it's really important that some of the stuff, whether it's addiction or some of these behaviors, those are really just leaves to the problem. There's something sometimes underneath that maybe patients haven't dealt with yet, haven't been able to look at. And when we're able to get people in here to this MAP program, we're able to get them connected, like I said, to therapy, drug and alcohol counseling, getting them their primary care and all their health stuff. And so it's a pretty cool thing to watch transform. And some people, like I said, when I first started, some people didn't understand a lot of this stuff, and there was sometimes a lot of judgment, a lot of stigma around people like, oh, we can't see those people. We can't. These people got addiction, and it was like, well, the way you're acting and your facial expressions is turning some of these people off, and they don't want to come and see you because you're being judgmental, or the way you're looking at them, and maybe you don't see that you're doing that. So it's really it's been good to be able to display this and people to kind of get that and see that, so I think that's been a good tool, and our patients love that. We can wrap them around with service. Can you click the next one, Jen, please? So we can go over this on dopamine and craving. We need 3 things to survive, besides oxygen, food, water, and dopamine. If you deprive study subjects of water for 3 days, then put them in a functional MRI and place water on their lips, their relative size of the craving is like a baseball. Do the same with food, and it's like a basketball. Then take someone with an addiction to opiates up to 1 year after their last use and talk about Oxycontin while they're in a functional MRI, and the relative size of this craving is the size of a baseball field. So I think that's pretty powerful just to look at. There's some other stuff going on there. You want to click to the next one? This is one of my other favorite quotes. If you never heal from what hurt you, you'll bleed on people who didn't cut you. And sometimes we got patients who are coming in here bleeding on people, whether that's anger, cussing people out or whatnot. And sometimes we got to be able to be there to catch them and create a safe space for them to be able to have that moment, and then connect them to our services or whatever services that are going to work for them. So I think that's also part of that trauma and figuring out, letting them recognize that and get them that safe space to work that out, because sometimes that's not worked out overnight. Sometimes that takes a long time. And for some people, it could be quicker. Some people, it's a little longer. And so just creating that safe space to be there and catch them. Next slide, please, Jen. And language is powerful, calling someone an addict, a junkie, liar, failure, criminal. I think the main thing that we all would agree on is that that's a human being, right? That's somebody's son, that's somebody's brother, that could be somebody's mom or whatnot. And how are we treating this human being? Are we treating this human being the way we would want somebody to treat our brother if they were addicted to drugs, or our sister, or our mother, or whatnot? And just really looking at that and how we interact with patients in our language is powerful. Even our patients call themselves these titles, but they're still a human being. And so that's important for them to know and for us to know. And I always do this thing in my groups, and they love it. I pull out a $100 bill and I tell everybody, who wants this $100 bill? And then everybody is like, I'll take it. And I'm like, all right, I crushed the $100 bill up and I said, who wants it now? And everybody's like, I'll still take it. And I'll rip it in half. And then they'll say, I'll still take it. And I'll say, what if I rub this in pee or poop or something else? And they're like, man, I'll freaking clean it. I'll put tape on it. That thing's still a $100 bill. Right. Exactly. So no matter what they've done or what's been done to them, they, as a human being, is more priceless than a $100 bill. And they have value no matter what. And I give them this term, it's unconditional significance, right? That no matter what they've been through or what's happened to them, they're still a human being and they got unconditional significance. And so that's important to instill that in our patients, because when they know they have value, then their behaviors and stuff and belief systems start changing. You want to change to the next one? And this basically goes back to the stigma, it says stigma is a secondary injury of substance use and can require treatment. Basically, treating people like human beings, talking to them right. Next slide. This is our staff. I think I put everybody on there that we have at all 3 clinics. Our drug and alcohol counselors, our MAs, and our manager. I put Joey on there from HPHP because he's always been there helping out with all this as well. And next slide. This is our main number now. I just was able to get this going within the last couple of weeks. So everybody's not blowing up our cell phones now. There's one main number that will go straight to all our medical assistants, and they will get us connected ASAP. So that's a number that you can pass out, give out. And like I said, I put the MAP brochure in the chat box. You can print that out, pass that out to whoever you want, and that number's on there as well. So that's what I got. I don't know who got questions. I probably went way over my time.